Now, once we have taken the history, we have carefully examined the patient, and we have done the gait analysis. We move to certain investigations. That yes, we know that this muscle is actually weak, or the reflexes are less, but document what is exactly cause. We have to go to the muscle charting and other investigations. In this section, we'll be going through what are the motor power and tone of the muscle, how the weaknesses and deformities analyzed, and what are the imaging and investigation, the neurophysiological studies which are done to exactly determine what is wrong with the patient and what is the diagnosis of the patient. So we have to function the muscle groups. For example, if we are patient is able to, for example, if patient is able to extend his or her knee, that actually means the quads are working. So that puts actually a different group of if the patient is able to flex the knee, this means hamstrings are working. So the muscles actually function in a group. We have to ask the patient to do certain motions. For example, flex the hip, flex the elbow, extend the elbow differently. That will point out what's exactly wrong with which group of muscles. Similarly, in case of a lower motor neuron lesion, if there is flaccid paralysis, usually the muscle is either absolutely zero power, or there is weakness of the muscles. In case of upper motor neuron lesion, although the muscle are paralyzed, that is, they cannot perform the movement which is required for them to do, but usually is actually there is spastic paralysis, that muscles appear tight, and increased tone is there in the muscles despite being paralyzed. So we have to go test specific muscles. Exactly each and every fiber could be difficult, but there are a group of muscles can be tested to broadly diagnose what is probably wrong and where the problem lies. Repeated muscle charting can be done. It can be clinical, so that we know if it's a progressive disease, how much it has progressed, or if it is improving, what is actually the prognosis of what is happening to the muscle chart. So, and this is the way it's been described, that muscles are graded. There is actually 6 grades. That one starts from 0 till 5. 0 is no muscle action potential or total paralysis. The muscle has no power at all. Then 1 is minimal muscle contraction. 2 is power insufficient to overcome gravity. That is, the muscle cannot move a joint against gravity. 3 is anti-gravity muscles, at least that muscles are strong enough that they can move a joint, although they are weak, but they can move the joint against gravity. 4 is they can move the joint against gravity, but it's less than normal power. And 5 is full power. That is, you call it a 5x5 or 4x5, depending upon what kind of a muscle power it is. So coming to the weakness, usually you have to address if we have to determine whether it's a complete paralysis or this is a weakness of the muscle, and what kind of the movements are actually affected. Then there are terms called as partial paresis or paralysis. Paralysis means complete absence and the muscle is completely lost. A paresis is actually there is although weakness, but it's not complete, the function is not completely lost. Then there are different patterns, and we have to do the muscle charting so that we can pick it up what exactly is wrong with the patient. For example, this is called as monoplegia. Mono means unit, a single, so it's actually weakness of one limb, or it could be paralysis of one limb. Lower motor neuron deficit, usually lesion in the distal part of the spinal cord, usually the lower limb is affected most of the time. But although monoplegia, still in rare cases upper limb can also be affected, but usually it's the lower limb. Then comes the hemiparesis or hemiplegia. Hemi is half side of the body. Either the right or the left side of the body is usually affected, and that is, if it's completely paralyzed, it's called hemiplegia. If it is weakened, there is complete weakness of the one side of the body, that is hemiparesis. Then is a diplegia. Di means two, and it's mainly involving the both upper and both lower limbs, but it can be either upper or lower. That is why when it's called as diplegia. If it's involving both the upper and both the lower limbs, then it becomes quadriplegia. It's quadriplegia means paralysis of all 4 limbs. Usually it's upper motor neuron lesion, but can be a lower motor neuron pathology as well. For example, cerebral palsy, polymyelitis are classical example which can result in quadriplegia. Now, these patients sometimes, due to neuromuscular imbalance, one group of muscle is not working properly and other is actually contracting at its full strength. As a result, this usually results in a deformity, or they actually present with some kind of a abnormal bowing or flexion contractures, which can be termed as deformity. So we have not only to look at what is the history examination and what is the muscle charting, we have also looked what kind of a deformity is actually if that patient he or she has developed as well. And this deformity could be due to unbalanced paralysis, that is one group is acting and stretching the bone and the ligaments towards the other side, the other group is actually completely absent, so or is not working, so therefore the result is a deformity of the bone, which is actually not a bony pathology but a muscular imbalance. Then it's called a balanced paralysis, for example, due to if all the muscle on the both sides are actually absent, this would probably result in no traction from one side, but as the gravity can act on any joint, therefore usually results in some kind of a contraction. Then it's called as a dynamic deformity. This actually happens is that muscles are slightly weak on one side is slightly less, but if that effect of gravity is actually removed, that the muscle power is actually balanced. And usually in certain situation the imbalance is there, but in normal situation the imbalance is normal. Then comes the fixed deformity. Once the soft tissue contractures have been developed due to long-standing muscle imbalance, this may result in contractures of soft tissue, which would require soft tissue releases and osteotomies in the bone to correct the deformity at times. And usually these bones, as they're diseased, not actually the bone is the problem, but because muscles, when they act on the bone, this actually was good for the bone as well. But in bone, those bones which usually have a muscle paralysis is associated bones osteopenia, that the bones become thinner and shorter and softer and increase the propensity to fractures. As it was told you, once we have checked the history examination, neuromuscular evaluation, we have checked the muscles, we have checked the deformity, then comes the autonomic system. That is whether the other systems are intact or not, whether sweating is there or not, or what about the peripheral vasculature, is it contracted or not. So we have to look at the sensation, which is actually tested over dermatomes. Then there is a deep sensations, this vibration, touch, proprioception. Then there's a pain and temperature, which is go on one in one track. Then we also have to look at the other sensations as well. The usually in case of, as I told you, in case of diabetes mellitus, there is always a glove and stocking type of neuropathy in which the patient complains of it that almost whole of the dermatomes are of the hand are involved. That usually hand has C6, C7, and C8 involvement. And if the multiple dermatomes involvement, that means either that it's a probably problem which is lying like C6, C7, C8 in the cervical spine, there's a problem, or there's a problem or something wrong with the peripheral nerves. That is why he or she is having a problem over here. Then we have to lastly look at the autonomic nervous system as well, such as sweating, color, warmth, and pseudomotor functions. Once we've done the history examination, we've done the muscle charting, we have done the active flexion extension, we know there is no whether there's contractures or not as well. We have checked the sensory system, then we have checked the autonomic system as well. Then comes imaging. Then why we need imaging actually is to document that our diagnosis, usually by this time we have narrowed our definitions to go 3 diagnosis, and to make it sure that what is exactly the cause, we have to move towards imaging. Now, imaging could be as simple as spinal imaging in form of x-rays. If there is nerve root compression, there usually may or there is a disc slippage, or there may be a vertebral slippage in case of spondylosis, that will probably be visible on x-ray. That usually identifies anatomy, site, and cause of the disease. Sometimes fractures and dislocation can be picked up on simple x-rays and CT. Prolapse intervertebral discs may be picked up on MRI. There may be a narrowing of spinal cord in CT or MRI. If the diagnosis is going towards spinal stenosis, we may see narrowing of spinal cord in CT or MRI. We may be able to pick up whether there's osteopenia, osteoarthritis, or the bone destructions, which maybe could be visible on X-ray as well as CT and MRI. Then sometimes this not only we need imaging of the spine to rule out whether the peripheral nerve injury as well. Sometimes the central nervous system is involved. We need to image out the brain as well. And probably some kind of a mass lesion present in the brain, which is causing this kind of symptom. We may need MRI and CT scan of the brain or PET scan to rule out if there is a deep-seated tumor in case of brain. Then there is, once we know, probably by this time we have reached a definitive diagnosis, and we may need additional investigations such as blood and cerebrospinal fluid. If we are suspecting some kind of infection, then yes, we need to do the workup, so we isolate the organisms and we can treat that. Other include muscle biopsy, although it's very rare, but if it's the patient has a Duchenne muscular dystrophy, then probably all the previous investigation will come out negative until unless you have a biopsy taken right from the quadriceps, so that there which would demonstrate a loss of dystrophin protein which is present in the muscles. If the problem is with the sensory neural deafness, everything else will be negative until we do the audiological ophthalmic testing. Then there may be assessment of mental capacity as well. That is usually depending upon case to case, what kind of a diagnosis and what are the differential is. We can go for sometimes additional investigation, sometimes simply the X-ray, MRI, and CT are more than enough to make a diagnosis. In this section, we have gone through that once we have done with our history examination and gait analysis, we now move on to investigate, because once we have made the differentials, we are moving on those non-invasive first, then from non-invasive to invasive first. Depending upon what kind of a disease is, we may be going for simple x-rays, may be going for a bit sophisticated investigations such as CT, MRI, or we may be going for another if we are suspecting some kind of a ENT issues such as sensory motor or this is hearing losses. Then probably we may have to go for audiological investigations as well. Thank you very much. Keep watching sqadia.com.